Well, welcome everybody to our continuing 2017 educational webinar series. I am Dr. Jill Brooks, Senior Director of Education for First Healthcare Compliance. At First Healthcare Compliance, we help you with a comprehensive compliance management solution tailored to your business, a hospital network, healthcare practice of any size, billing company, or skilled nursing facility. As part of our complimentary educational webinar series, we bring you experts from around the country to discuss relevant topics in the healthcare industry. We wrap up this month with focusing on patient safety. Today we have David Sommers presenting Patient Safety Challenges, Communication, and Resolution Initiatives. Dr. Sommers is a board-certified anesthesiologist, lawyer, and businessman who is currently engaged in the private practice of medicine with Great Lakes Anesthesia, as well as healthcare compliance consulting. He has several years of law practice experience. Dr. Sommers serves as the Great Lakes Anesthesia Medical Director in the Parkview Community Hospital System and Chief Compliance Officer. Dr. Sommers has an LLM in healthcare law from Loyola University School of Law in Chicago, Illinois. He was one of the founding partners of the Unified Anesthesia Services in Terre Haute, Indiana. Additionally, Dr. Sommers was a co-founder and former partner in Strategic Healthcare Group, a leading provider of blood management consulting, education, and informatics solutions for hospitals, healthcare systems, and blood collection operations across the United States, which was subsequently acquired by MediWare. He has developed expertise in risk management, healthcare compliance, medical malpractice, informed consent, patient safety, and the medical legal aspects of blood component and drug therapy. He has consulted with private industry and the American Red Cross on transfusion strategies and liability attributable to blood component transfusions and related drug therapies. Dr. Sommers has given numerous presentations at national meetings on patient safety issues, informed consent, and physician, hospital, and blood industry liability related to transfusion therapy. He has hosted numerous grand rounds for hospital staff throughout the nation on transfusion therapy and strategies, informed consent, patient safety initiatives, and medical liability. A copy of his slide deck is available for download on the control panel. Feel free to submit questions into the question box on your control panel, and we will address these at the conclusion of his presentation. Your Paycom CEU certificates will be emailed to you from Paycom following the broadcast. There is no need to request your certificate. Additional CEU opportunities will also be available to BC Advantage members following the live broadcast. You'll have to check their website for details. Okay, go ahead, David.
All right, thank you, Jill. Again, sorry for the difficulties in getting connected, but I want to talk today about communication and resolution initiatives. We've got a lot of slides to go through and less time than we had before, so we'll just forge on. Traditional response to patient harm is also often a deafening silence from healthcare organizations and healthcare providers. This, coupled with the realization that the tort system does not always meet the needs of injured patients and the cost to litigate and the large verdicts that can occur, in addition to the fact that we really haven't impacted preventable medical errors and harm, has led many organizations to look very carefully at this area and to try to find a alternative to litigation and how we as providers and organizations respond to patient injury. Thus, the creation of these communication and resolution programs. We'll talk about the Candor Program as well. These are open, honest, transparent initiatives that directly take head-on the patient harm and discuss and talk about the issues with patients and their families. And it's really a very provocative area that we'll talk about today. As we get into this, I want to go ahead and just show a quick video to kind of set the stage for where we are today in our discussion. This is actually a video from the Candor website, which I'll talk about.
I have a beautiful blonde hair, blue-eyed 9-year-old daughter who is a quirky little girl, contagious laugh, funny, avid reader, and she was a blooming artist and an athlete, and she's no longer with me anymore. She died of medical errors. She got a hospital-acquired infection. She was a classic case of failure to rescue, where all the signs were there and that she was deteriorating and no one did anything.
At any one time, 1 in 25 hospitalized patients has a healthcare-associated infection, or HAI. About 75,000 hospital patients with HAIs died during their hospitalization. In the case of Carol's daughter, Alyssa, the hospital's response was less than optimal.
She was in a teaching institution where the fear of hierarchy was there, and the resident didn't go up the chain of command. The organization where she died shut down on me. They wouldn't talk about what happened. They would not give me her medical records. It took the organization where she died 3 years, 7 months, and 28 days to have a conversation with me.
The current system doesn't work well for patients or providers or hospitals. When harm occurs, the strong tendency for hospitals is to disclose as little as possible about what's happening.
For Dr. Heather.
And that's our video. We'll get back to the slides here. I think that really sets up our talk today and the areas that we want to discuss. Everyone in healthcare wants to provide excellent, high-quality medical care, but despite this, despite our patient safety work, patient harm is way too common. Organizations have quality and safety programs, but many struggle to ensure that the solutions to errors are really addressing the cause of the error and not just checking off the box of the process when they do their analysis of the error. Patients want healthcare organizations, physicians, and care providers to be fully transparent when an error occurs, but this often doesn't happen, as we saw in the case of Carol. If, as a corollary, we are required as physicians by the doctrine of informed consent to discuss and disclose risks, benefits, and alternatives for treatment processes and procedures, should we not then have the same requirement when something untoward happens? Excuse me, sorry, our slides are kind of going out here a second. Having some difficulty with them. Try to go back here. Sorry. So I was making the point that we have to, under the doctrine of informed consent, we have to tell everything, risk, benefits, and alternatives and procedures. When something bad happens, we should also be just as upfront and about those harms. Inside the walls of American hospitals, incredible feats of healing and medical care occurs every day, but when there's an unexpected event that happens or harm that happens, whatever the cause, a wall is suddenly created. This invisible wall of silence, built in part out of legal worries, keeps patients and families from getting information about what happened and compensation for suffering, or simply an apology. It also keeps doctors, nurses, and others from being able to learn from mistakes and near misses, and causes them emotional trauma as well. Well, what is the problem? We're human, we make mistakes. The seminal discussion and report by the Internal Institute of Medicine in 1999 demonstrated that about 98,000 people die per year due to preventable medical errors. In 2001, the IOM came out with another report. This is called Crossing the Quality Chasm. In that report, it discussed patient-centeredness, and by that it meant care that respects patients' preferences, needs, and values. And those are very important for a high-quality healthcare system. Also, it talked about open and transparent bidirectional communication between patients and physicians as the foundation of this patient-centered care. The problem is the current strategies are not very effective. In fact, medical error may be the third leading cause of death in the United States. That's amazing. Dr. Macquarie looked at previous data beginning with the Institute of Medicine's study in 1999 and further, and has made a determination that as many as 195 to 400,000 people per year may die due to medical errors. This is significant also because many of these studies don't account for outpatient setting problems or in-health home nursing home care. So based upon all this, he suggested that the number of deaths were really about 250,000 per year due to medical errors. And we're not making really much headway. 13.5% of hospitalized Medicare patients suffered an adverse event. This is from 2010 Medicare data. 44% of those adverse events were preventable. So we have a great gap here that we have to address. Well, what's the traditional response to patient harm by providers and organizations? It's kind of what Carol discussed in her video. We circle the wagons, we deny and defend. Under that model, the healthcare community categorically rejects fault for adverse events and outcomes in complex medical and emotional symptoms those issues are systematically turfed elsewhere, sometimes to lawyers. Attorneys on both sides focused on winning a case really stonewall the patient. There's no discussion, no honesty, no openness. And patients are kept in the dark about clinical decisions and events related to their care and often described, as she did, feeling abandoned. For all members of the healthcare community, deny and defend or circle your wagons provides a disincentive for investigating clinical events and decisions for fear that such scrutiny might reveal compensable errors. And don't get me wrong, medical liability litigation is still a very powerful force in the United States healthcare community. The mere possibility of being sued affects the clinical decisions, strains physician-patient relationships, and shapes professional experience and attitudes of physicians. And this can be really devastating. As I said, and the slide says, as concerns about why we don't like to talk or disclose our errors or our mistakes, we grew up in a blame and shame program. We were trained that if something happened to our patient, we were responsible. We're also concerned that any malpractice payouts might be reported to the National Practitioners Database, that it affects credentialing and reputation. We also don't have the skills. We're not trained how to disclose errors to patients and how to talk to them openly and honestly about it. How do patients view this traditional deny and defend approach? Well, you can understand. They believe that if you don't talk to us, then you're essentially acknowledging that you committed an error, or that you're hiding errors, that you don't respect us, that you're callous and uncaring, and that you essentially shrug responsibility. What do patients want? Well, of course, they want the truth. They want the facts. They want emotional first aid as well. Empathy, compassion. They want recognition, validation of those emotions. They don't want to feel, as Carol did, they don't want to feel abandoned. They want accountability, and sometimes that includes an apology. They also want to know how you, as a practitioner, if you committed a medical error and caused harm, how you will try to prevent that in the future. Have you learned from that? Well, how are we doing? Well, we're not doing very well. We don't disclose our medical errors, and even when we do, we often don't meet the expectation of the patients. And as I said, we're not trained as physicians and other caregivers, we're not trained how to disclose when we have problems or when we encounter mistakes. And we will make mistakes. We are human. We are fallible. We will make mistakes, and the data suggests that. And the fact that we haven't impacted the amount of errors over this period of time since the Institute of Medicine's landmark report is very telling. There's also a point of patient autonomy here, that physicians have to be honest with patients so as to foster informed decision making. And then honesty must include promptly informing patients of medical errors when they happen. Well, the U.S. healthcare reform is all about change and improving patient safety, decreasing error rates, and impacting medical liability costs. But to do that, we really need to develop a transparent culture. We need to effectively communicate with our patients. And we've got to quickly resolve and engage patients when there are adverse events. Well, as I said, many individuals looked at the problems, they looked at these issues, all these risks involved, and they wanted to create programs that sought to effectively communicate with patients and their families after the immediate incident of or patient harm, regardless of the cause of that harm. And they realized that if we did this, it could lead to organizational learning, improve surrogate measures of patient safety, and possibly a reduction of medical liability. That wasn't their only goal, but these other things of learning as an organization, impacting medical errors, creating patient safety initiatives, and stronger support in that regard was really, really appropriate. And one of the reasons that we created these alternatives to litigation and these communication and resolution programs are also called offer, disclosure, and apology programs. Well, one of the first programs to develop was in the VA Medical Center, of all places you might suggest. In Lexington, Kentucky, the chief of staff there, a fellow named Stephen Cramen, created a risk management committee charged with developing procedures that would decrease medical malpractice litigation against the hospital, in part because they just were whacked with a $1.5 million jury verdict in a malpractice case. And he said, there has to be a better way. Well, this group looked at the area and they looked at the facility's litigation history and found that when hospitals failed to handle the patient's concern, the potential for a lawsuit increased. The committee determined that a hospital had a duty to remain as a caregiver after an adverse event occurred. In that capacity, the hospital must fully disclose information to the patient. So they developed this program: disclosure, apology, accept responsibility, provide compensation where appropriate, and do a real analysis of an investigation and try to learn from the issues and the problems that occurred. In 1997, he published a comparative analysis of payments of medical malpractice cases by the VA Medical Center and other similar institutions. The overall cost of their hospital was in the lower quartile of the centers reviewed. So there is some data that this helped and was impactful. In other programs developed based in part on this experience at the University of Michigan and University of Illinois, and we'll talk about those. These programs encourage the disclosure of unanticipated care outcomes to the affected patients and proactively sought solutions. And in terms of patient safety, early and open communication with patients is not simply the right thing to do, it's the smart thing and the only thing to do in my view. Ethical obligations and patient safety principles support prompt disclosure of harmful medical errors. In fact, disclosures can strengthen the trust in the patient-physician relationship and is widely regarded as the appropriate thing to do for healthcare providers and hospitals. However, the fears that disclosure will invite new claims or complicate subsequent litigation certainly can inhibit the impulse to disclose. In 2001, Richard Boothman, who is the risk manager at University of Michigan, and others launched this comprehensive claims management model at Michigan with disclosure as its centerpiece. They recognized that they could not promote an effective resolution of anticipated outcomes if they didn't know about those events. So they had to create a strong culture of early reporting of these events to have an impact. Their program was informed by two central observations: that honesty is indispensable for safety improvement, and that a short-term focus on financial risk impedes long-term improvement. Three other guiding principles: compensate quickly and fairly when appropriate, vigorously defend appropriate care, and try to reduce patient injury and claims by learning what happened, learning from the mistakes that were made. So in a sense, they would gather the facts, they would presume good intentions in all the parties, they would be truthful and open and honest in disclosing what happened to patients. They would focus really on the patient's interests. Those became primary. They wouldn't speculate, and they would plan on following up communications with patients, continuing to engage them throughout the process. They developed an internal review committee that was responsible for determining various things regarding the investigation once it was completed. Was the care reasonable? Did the care negatively affect the treatment outcome? And also, was there peer review needed, quality improvements, or other additional and training modalities or needed to address what occurred? And they implemented this program, this full disclosure program. And who was responsible for disclosure in this program in University of Michigan Health System? Well, it was the attending physician who was involved in the error process. They would have risk management support, and they would be honest and open with patients. They would meet with patients. They would give the patients the facts of, as they knew them, of what happened to their loved one. They would describe the anticipated outcome. They would talk about the impact of the error, the health impact of the error on the patient. And they would disclose treatment plans and a timeline for those treatment plans. What were the results of this program? Well, they were significant. They had fewer claims per patient encounter, fewer lawsuits per patient encounter. There was a decreased median time for claim report to resolution. The average monthly cost rates decreased for total liability, patient compensation, and even non-compensation related medical cost. So here's some of the first data that suggests that full disclosure of medical errors, even with offers of compensation without increasing total claims and liabilities cost. This was really a significant finding, and based upon this, other programs started to look at this. At the University of Illinois, one of my mentors, Dr. Tim McDonald, was intimately involved in developing this program. This program is called the 7 Pillars Approach. It was part of the University of Illinois Medical Center at Chicago. In view of the medical crisis, liability crisis in Illinois, in particular Cook County, and the realization of all these potential preventable deaths that were studied and reported by the Institute of Medicine and others, they created this resolution and communication program in part based upon the Michigan model. The driving force for them was early and consistent communication maintains trust, maintains that relationship with the organization and the patient and the physician and the patient. They also believed that in doing so, they could improve learning. They could look at these, they could analyze, they could investigate, they could determine what mistakes were made and how to correct those and how to learn from those mistakes going forward. They wanted better outcomes, obviously, and they wanted, if possible, to reduce their medical liability. This 7 pillars intervention includes, as I said, rapid reporting. In fact, once the incident is reported, and by the way, there are incentives for providers and individual departments, monetary incentives, if you will, to always be on top, always report a patient incident. And this rapid response sought currently to provide support for the patient, family, to investigate the event, as I said, and also to provide ongoing support to the caregivers. And this communication with families occurred within 15 to 30 minutes after notification of the event and continued throughout the investigation period. The guiding principles, again, was that effective and honest communication was the only way to go in this scenario. That apology and rapid compensation, where appropriate, was the right thing to do. They would again vigorously defend what they thought was reasonable Medicare, and they would try to learn from their mistakes. They also, in order to do this, had to develop a just culture. Now, a just culture avoids the blame and shame approach to errors, recognizing that errors aren't necessarily always due to individuals' failures, but they're due to system failures. And they did this in part to offer provider protection for patient safety incidents that occurred, again, as they said, because of system failures. The safeguard was appropriate because of physicians' fear of participation and exposure to liability if they were involved in this program. They would address, of course, reckless behavior very quickly and appropriate, and they would also support the caregiver as well, provide care to the caregiver. Interestingly, the program really struggled initially to overcome physician skepticism. Many physicians were uncomfortable about making disclosures, in part because they lacked training in disclosing errors, in engaging patients when a problem occurred, and they also had a cultural disinclination to admit that they had made a mistake. Part of this, again, is from their training, from their residency training, both and as well as medical school. And what they did to address this is the leaders worked to shift the physician's focus from the legal risk to doing the right thing. So this 7 layers of disclosure, if you will, this rapid response, again, focused on prompt reporting. Really, and engagement, communication with the patient within 15 to 30 minutes after the incident. They would also contact accounting and suggest holding the bills and the professional fees until they determined what happened. Once a consensus was reached as to the facts, including the potential factors leading to the event and possible breaches of standard of care, a patient or family meeting was convened to discuss the findings and the event analysis. And where appropriate, as I said, to admit mistakes, offer an apology, discussion of the appropriate resolution, including significantly a promise to waive or reimburse patients for all professional and hospital fees and the cost of future care associated with preventable harm in certain instances. They also did data tracking. They really embedded this process into the culture of their organization so they could learn from the mistakes so they wouldn't create the error or create the situation that led to the error again. Well, what were the results of these 7 pillars approach? Well, they were fairly significant. They saw, in comparing the pre-intervention period to the post-intervention period, when they began the process and the program, they found that they had a reduction in the number of claims, in the legal fees, the legal expenses, cost per claim, settlement costs, self-insurance costs, and also the median time to disclosure. So this data, plus the other data that I showed you regarding the Michigan model, shows that telling the truth to patients and families and offering early resolution after adverse events does not produce any significant negative liability consequences. Again, validating this approach, validating this program. Now we're going to talk about the Candor Program, which is a Communication and Optimal Resolution Program. It was created by AHRQ, the Agency for Healthcare Research and Quality. It was created in 2012 on their website. In 2016, they published a toolkit, a rather extensive toolkit with 8 modules that details this program and how to implement this program in your own organization and own system. It's a change management approach, and it's very, very provocative. It is an integrated set of processes that look at events and system activation, response and disclosure, analysis, investigation, resolution, remediation, and also importantly, care for the caregivers. Richard Boothman also wrote this article about Candor and whether or not it was the antidote to the deny and defend paradigm. And he focused on sort of the pushback that he got from risk managers, lawyers, even executives in the hospital. Why in the world we want our practitioners to be open with patients about our faults and their harm? Because that can be used against us. Well, again, he answers this question based upon the data that I've shown you, that this deliberate strategy, intent on normalizing honesty, transparency, and accountability, can impact the bottom line, certainly, but also can help the organization learn, become a stronger organization with a true sense of culture, of safety and honesty that's indispensable for any organization's mission. The Candor process, again, is this approach that you respond quickly, timely, thoroughly to unexpected patient harms. Although you can't always undo the harm that occurs, we can certainly change the way we respond to it, and this is part of the Candor process. What are the Candor goals? Again, we've outlined these in part: improve patient safety and quality, prevent patient harm, support patients, families, and also, very importantly, caregivers. And the thought to reduce litigation frequency and cost as well were very important. But the goals of the Candor process demonstrate the respect for patients, families, and caregivers that are impacted by harm, and attempting to address many of the quality and safety processes identified by healthcare organizations. Carol, the patient advocate and just delightful person that discussed her loss of her daughter, has this wonderful quote I have here, which is also taken from the Candor website. By the way, the Candor website is open for all people, all organizations. You can take and use slides from them, and you can use the process, the videos, and it's very, very good for education. But this quote that we know mistakes are going to happen, and we can forgive those. But you harm us again by not being honest and transparent with us. And she notes that we should be those that suffer harm, those families that are impacted by harm, and the organization could be healing and learning together. And this is something that really, really needs to happen. Well, as I said before and previewed, in part, we haven't made much headway on safety, in part because we've struggled with transparency. In this Health Affairs article in 2012, it noted that doctors don't always disclose medical errors. In fact, 1/3 of docs didn't agree with disclosing serious medical errors. In Rosemary Gibson's book, The Wall of Silence, she notes that responding to medical error is part of the healthcare where we should be at the best, most patient-centered. This was our true stress test, but that we often don't do this. Nevertheless, we know that informing patients fully about medical errors can reduce anger and also lessen patients' interest in bringing malpractice lawsuits. As she said, consequences of not responding appropriately to medical injury, not being open and honest, you compound the suffering of patients and families. You certainly heighten the distress of those involved in the adverse event. You also increase the likelihood of litigation, and it's a lost opportunity for improving quality when we don't engage the parties. It can degrade the institutional culture and climate, and really reduces trust in the organization when it seems that we don't have healthcare and patient safety as our overriding principles that need to be addressed. Why are we not open and honest? Why are there barriers, both perceived and real, to disclosures to patients about adverse events? Well, we talked about the barriers, and those fears are very real. Litigation, data bank reports, the shame and blame of committing a medical error, reputation, lack of skills. But there are benefits to disclosure and being open and honest and transparent with patients. Organizational learning that leads to improvements, those things can occur. The potential decrease in adverse events, certainly less litigation, lower cost, absolutely, but also improve morale and trust as organizations and caregivers see that everyone's mission is to provide quality and the best care possible. Certainly, though, the fear of this report to the National Practitioners Data Bank or other licensing agencies is still a very real impediment to open disclosure, apology, and communication. For an organization in the Candor process to be successful in getting events reported, the organization must have a just culture. This just culture is crucial to the a crucial accompaniment to the Candor process and its framework, and will spark shared accountability that is necessary to make this a real possibility in your organization. In just culture, there is not only a shared responsibility, but a commitment to eliminating the possibility. And this is widespread within the culture. This is the cornerstone of the Candor process, of investigating the root cause of how an error occurred, including the human factors, and the entire organization must support this culture change. In the traditional deny and defend paradigm, hospital staff that commit mistakes feel the burden, and they feel that these mistakes that they've made will be held against them and noted in their personnel file. In this punitive culture that does not strive to understand potential underlying reasons for behavior, transparency is impossible. But transparency is vital to addressing the factors that contribute harm, and to develop this and sustain this culture that we've talked about, promoting candid, caring communications and timely resolution of harmful events with patients, families, and caregivers. Well, what about our safety attitudes? Well, Lucian Leap, one of the main heroes in the field of patient safety at Harvard, notes that we don't have much impact on reducing medical errors because we focus on the individual and those making mistakes. And when we do so, we make our own mistake, because we have to recognize that we are human and we will commit errors and we will make mistakes. James Reason, also an expert in culture safety and change management, also notes that humans are fallible and that we must create systems that address these sort of things. And what do I mean by a system? Well, human error, again, focusing on human error is a fruitless goal. It misdirects our resources and focus, and it actually creates a culture of blame and collusion and secrecy. Sorry, my slides are jumping ahead somehow. I apologize. But really, the whole goal here is to focus not on individual blame, individual liability and errors, because they will occur. But they're typically not due to negligence or intention, but rather due to the human factors, such as knowledge deficits, distractions, biases, performance under stress, and so-called system factors as well, such as work environment, production and time pressures, sudden unexpected occurrence, rapid changes in the condition of patients, for instance. So we need to focus on not who is responsible, but what is responsible. And system errors really do cause the majority of the casualties, rather than the poor performances of our individual practitioners, which may be somewhat of a change to what you might have thought in the past. And we really need to shift the blame from blaming individuals to designing systems and safety into systems in order to really affect change in the process. The human engineering factors are very important when we redesign the systems that we work in. This is an approach taken in the aviation industry, and it's also taken in the healthcare culture as well. As I said, most errors are due to system failures, but in addition to individual fault, we continue to punish the person without altering the systems, and thus perpetuate this problem without really resolving it. So it's really important to apply a best approach to avoid errors and near misses by analyzing the error and then creating mechanism to avoid such mistakes from happening in the future. This slide talks about or describes the communication and optimal resolution, the 5 steps: identification, activation, response, disclosure, resolution. We'll talk briefly about those. This is an integrated approach, as I said, that's set out so well in the AHRQ website. But it centers on communication and effective communication, not only with family and caregivers, but the patients as well, and all that are involved in patient safety events. When an organization decides to adopt the Candor process, to attempt to implement it, there has to be a gap analysis. You have to review the policies and procedures to get a snapshot of where the organization is. And this gap analysis includes also interviews with various leaders, frontline staff. If you will, it's a top-down, bottoms-up approach, a change management effort involving organizational leadership and champions at every level of the staff. And here is this assessment on the left hand of the slide, about 3 months to get a gap analysis, organizational buy-in support, 12 months to engage in the implementation of the 5 steps, and then about 3 more months for developing a sustainable model with organizational learning that can move forward. So identification of a Candor or an adverse event is the first step of the process, and the organization must work to help clinicians understand what a Candor event is and how to recognize that event. And that can be recognized by a number of different ways: verbal communication with risk management, patient safety personnel hotline, electronic reporting system, many other means, and these are all set forth in the implementation model on the AHRQ site. Key elements of event reporting supports, again, a rapid response. Important to obtain feedback from both providers and staff and patients and family who are involved in this. It involves or allows for immediate, anonymous, and even confidential reporting of medical errors or patient safety incidents. And it really does provide protection of event analysis from discovery based upon medical peer review and other quality initiatives in the hospital and the organization to be consistent with protections both on the state and federal level. It provides immediate and ongoing feedback to the individual that made the report, that filled out the MIDAS report or whatever you call it in your organization to begin the whole process. And all of these elements, though, support the foundation for a resilient reporting system, and it is so important. Well, what is their definition of a Candor event? A Candor event is an unexpected harm to a patient, physical, emotional, or financial. And Candor events trigger the process even when the cause of the event's not known. And again, near miss in unsafe conditions are very, very important, but they are not Candor events, and they don't activate this Candor process. As an organization, you must emphasize the importance of reporting these incidents and removing the stigma attached with reporting. But once a report is received, the organization then activates the system. Designated staff respond to go directly to the scene and engage the patients and family. There's also an activation of the Care for the Caregiver program that will provide support to those involved in the untoward event or patient safety incident. There will be a call out to accounting to hold the fees and professional facility fees related to the patient's care until an event analysis has occurred. And again, there will be engagement of staff at all levels, those that are involved and those that are responding to the event. Within 30 minutes then, the system is activated. Within 30 minutes that the event has been identified, the Candor system is activated. And again, this requires or permits the Candor response team, and all these teams have various names that are adopted in the organization. There's an investigation and analysis core team, a Candor response team, a Candor communication lead. The response team immediately goes to the caregiver where the event occurred and helps ensuring that the patient is clinically stable and safe. The investigation and analysis team begin their fact-finding investigation, and the communication team provides immediate emotional support to the patient, family, and any caregivers that might be involved. Within 60 minutes after the event has occurred and has been identified the response and disclosure segment is activated. This team is responsible for this initial communication with the patient and the family. And following this initial disclosure and conversation with the patient and family, there will be ongoing communication engagement as we learn more about the patient safety incident. And then a trained communicator comes on and would establish this regular communication with the patient and the family. And how to train communicators and how to engage in this process is described at detail in the Candor implementation guides. Within 72 hours then, the investigation and analysis process is already ongoing. As I sort of indicated before, steps 3 and 4 kind of are ongoing and occur concurrently. And this 72 hours post-event investigation analysis, what is done there? Well, they schedule interviews, complete interviews, review the records, gather any data or evidence that they can. As I said, the billing process is held until such time as a final determination is made. They also notify a liability carrier as well. 30 to 45 business days after the event, there's been an analysis, an investigation team that has looked at the causal factors. Was the standard of care breached? What other evidence of mistakes or errors may have occurred? And there's various meetings that occur during this time period. And ultimately, when the investigation is complete, all this information is shared with the family, providers, and the caregivers, and certainly the insurance carrier. And I wanted to compare and contrast the sort of Candor process, the disclosure apology process, versus what might traditionally occur in an investigation and analysis in an organization that doesn't have any of these type of communication and resolution programs. After the event, about 2 to 4 weeks later, a root cause analysis team would then meet. They would determine the root causes for the event, assign a solution to each cause, and a person responsible for implementing the solutions to the root cause. This information then would be sent to leadership and the board. There would be a follow-up probably about 6 weeks later to ensure compliance with whatever solutions were determined based upon the investigation, and then they would close the investigation. Well, there are many gaps in this process. Again, this is distinct from the Candor approach. First of all, you look at the time frame, the length of time here is significant. And the process doesn't support any immediate action with the caregivers, with patients, with families. Due to the length of time to respond to this investigation and analysis, memories start to fade, reports, data may be lost, so there's a real opportunity lost. Also, as time goes by, because patients and families haven't been engaged in the process, they may start to develop distrust. They may believe the organization is hiding the truth about the event. And there's limited time, as I said, for involvement of caregivers. In fact, caregivers really aren't contemplated in this traditional deny and defend paradigm when investigating an adverse outcome. And this, so this is a very limited response, and a very, it's detailed, but it's very limited in the sense there's no engagement on either level, and it's very distinct from the very quick response of the Candor program. Well, we talked a little bit about care for the caregivers, why it's important to support caregivers. And it really is. In fact, I'll be talking in December about these sort of programs and processes. A caregiver that's involved in an adverse event is called a second victim. The first victim, of course, is the patient and their family. And this second victim are all healthcare providers, nurses, pharmacists, who's ever involved, others who's ever involved in an unanticipated adverse patient safety event, in a medical error or other patient-related injury. They become victimized in the sense that they're really traumatized by this event. These individuals often feel personally responsible for the patient's outcome. Many feel they fail the patient, they second guess their clinical skills and knowledge base. In fact, multiple studies have shown that involvement in medical errors and adverse events can take a significant toll on caregivers and clinicians, and in fact, it's estimated that 1 in 7 patients is affected by an adverse event. So this is significant. There are many opportunities that this will happen, and there's likelihood that this will occur in your organization. In fact, 50% of all clinicians will be involved in a serious adverse event once in their career. So they definitely need support, and the slides slipped ahead again, and I apologize for that. But these individuals really have problems. They, as I outlined before, they have problems with respect to their skill set and knowledge base. They risk depression. They also are higher likelihood to be involved in future errors. They have burnout. Their risk of suicide and substance abuse increases substantially. Many think about leaving the practice of medicine, nursing, or other roles, and many in fact do if they don't receive the appropriate support and coping strategies, counseling that these Care for the Caregiver programs can provide. The last slide, or the last set of slides here, talks about resolution. Obviously, this is after the events have occurred, and there's been a determination of what response the organization ultimately has to make. And this is, they sit down with the family, they get this information, and then they give the information as to whether or not standard of care was breached, whether the organization has determined, based upon their analysis, if compensation is warranted. And this can be a very emotional disclosure, very emotional for caregivers, very emotional for patients and their families. And these conversations differ significantly to the initial response and disclosure process and engagement with patients that occurs directly after the adverse event. So there's, again, training for risk managers, other organizational leaders in how to deal with these meetings and how to address these sorts of things regarding compensation, apology, blame, mistakes, those sorts of things. So it's a very specific approach that Candor has outlined. Well, again, I apologize. For some reason, my program is moving me ahead. This is my last slide. In summary, I just wanted to go through the difference between the traditional response to patient harm and the communication and resolution response, specifically Candor, if you will. Well, with respect to the patient and family involvement, in the traditional response, we're going to deny, we're going to defend everything. There's no response, essentially. In the Candor process, it's extensive and ongoing engagement of those involved in the harm. There's communication with the patient family, transparent and ongoing in the Candor process, and deny and defend, there's really none. The event analysis in the traditional response, basically it blames the providers, the physician or nurse, or the root cause of the problem. In the Candor process, we focus on just culture, the system factors, and the human factors as well, but we don't blame, we look for system solutions. Financially, in the traditional response, if you roll the dice and you are lucky in the malpractice accident and you win or settle, you get money. In the Candor process, you may be compensated if the organization determines that there has been a mistake, an error, and they're responsible for it. There may be compensation. As far as quality improvement, the only response traditional deny and defend paradigm has is train and educate, retrain and educate. The Candor process, however, uses this data to drive system change and disseminated learning, so it's a very distinct process. Well, that's a whirlwind, and I apologize for the 7 or 8 minute delay initially in getting connected. Are there any questions at this time? Jill?
Yes, David, we do have a couple of questions. In the organization, who needs to be involved in the Candor program?
Well, it's really all levels of the organization. From the there has to be a buy-in at the C-suite, and physicians, nurses, pharmacy, everyone has to be involved. This is a, as I said, top-down, bottom-up approach. Everybody has to buy in. In order to create this just culture, everyone has to be involved in this. And the AHRQ website and toolkit sets out all the different elements where individuals involved, and certainly getting champions on each of those levels is very important to have a successful implementation. Change management is hard, but the Candor toolkit goes into the John Candor approach, creating a sense of urgency and engaging providers and other staff, and is very good, really, at providing information for that.
How can medical malpractice litigation prevent parties from an open discussion of an underlying adverse event?
Well, as I've talked a little bit about, once that lawsuit's filed, once the claim is filed either with the Department of Insurance or certainly with litigation, and really with the courts, and really as soon as an adverse event occurs, risk managers and other risk personnel often tell the doctors and other providers not to talk about the incident. So this wall is suddenly created where we become adversarial. There's no chance to penetrate that wall and reach your hand over it or through it and have an open and honest conversation, because now it's adversarial. And believe me, anything you can and will say can be used against you in a court of law or otherwise.
Can you define second victims and reasons to provide them support and guidance if there's an adverse event?
Well, yeah, we talked about that a little bit. Second victims are those really individuals. Has to necessarily be a physician. Can be a staff, any staff person, nurses, pharmacists, for instance, anyone that's involved in an unanticipated outcome with a patient, anyone who's involved in a code situation that doesn't go well, or does go well, can be a second victim. Again, as I said, I don't want to take emphasis off the first victim, because those are patients and the families, but there is harm in a sense to the second victims, and it's almost like a post-traumatic stress disorder. And there's a lot of literature on this. As I said, I'll detail this in fine fashion in my December webinar where I talk about these things. And these people really are really significantly impacted. They increase rates of suicide, depression. They feel personally responsible. And if you don't reach out to these people, provide counseling, support, helping them cope with either by peer support or otherwise, it can really have a profound effect.
All right, well, in lieu of the time, I think we're going to stop. We'll take the other questions offline. Please use David's contact information if you have additional questions, or if you send us questions, I will forward them on to him. Your Paycom CE certificate will be emailed automatically. You do not need to request it. Please register for our next webinar, which will be July 11th at noon Eastern Standard Time. Is this a HIPAA breach, and if so, what now? With Jennifer Kirschenbaum of Kirschenbaum and Kirschenbaum. And also July 12th at noon Eastern Standard Time, HIPAA Security, Monitoring Access, Incident Detection and Management with Ray Ribble of Sphere. You can register for these webinars or request a demo of our compliance solution on our website at 1sthcc.com, or give us a call at 888-543-4778. David, thank you again, and thank you everyone for joining us, and thank you for hanging on there in the beginning when there was a little bit of a technical difficulty. Thank you so much.
Thank you.